So this is a pretty typical case of metastatic colon cancer. 53 years old, probably never had a colonoscopy at this point, presents to primary care and ultimately to a gastroenterologist with some abdominal complaints and rectal bleeding. Gets a colonoscopy and the finding of a descending mass, a mass in the descending colon. Biopsy positive for adenocarcinoma, sent off for genetic testing. In the meantime, has a CT scan showing, unfortunately, metastatic disease, one big spot in the lung and a bunch of spots in the liver. And that's very important when we think about resectability and all of that. Symptomatic with this abdominal distension and the like. Biopsy comes back, as I said, adenocarcinoma, and genetic testing for RAS shows that there's a KRAS mutation. So the patient has a KRAS mutated, left-sided colon cancer with mets in the liver and the lungs, a little hypertension. Mom had breast cancer, but no other real family history of cancer. And the decision was made to go ahead and initiate therapy with chemotherapy. And there are a bunch of choices here. And I think the physician did what most physicians do in the United States, and that is an oxaliplatin, fluoropyrimidine, in this case Folfox, plus bevacizumab. Primary is still in place. No surgery has happened to remove that primary. But even with the rectal bleeding, that was done. And in this guy's case, good decision. The cancer responds nicely. There's a nice regression of the primary and of the other metastatic lesions. Chemotherapy is continued. Typically now, with metastatic colon cancer, we say folks are going to live 2 to 3 years. We're learning more about being able to be more specific, because we all know there's some patients who have a very short prognosis and others who have this forever prognosis. They do very, very well over a long period of time. And to date, we have just been treating them and see what happens. A guy who has a really nice initial response like this would be one of those people I'm thinking is going to be around a while. We now know, for example, BRAF mutated tumors, they don't do so well, they don't respond as well, so I'm more anxious about that person's prognosis than a person like this. So 2, 3+ years is what we would tell the patient. At 53, that's still way too short. So in this case, the patient's tumor was sent off for molecular testing, and this has been a really rapidly moving space as to what you need and when. And it wasn't a year ago that we said, oh, if they're metastatic, you don't need MSI. If they don't have a high family history, this sort of thing. But that's completely different now. You must have microsatellite instability testing on every patient with colon cancer, regardless of stage, regardless of age. 2 reasons. One, of course, to screen for the genetics. Is the patient a Lynch patient? Do they have HNPCC? But honestly, more importantly now, we know that those patients with MSI high colon cancers respond really well to the immunotherapy drugs, to the checkpoint inhibitors. And already on guidelines, you see MSI high metastatic colon cancers being recommended checkpoint inhibitors. So we want to know in this guy right from the get-go. Absolutely, we want to know the RAS status. Let's make this guy, instead of KRAS mutated, KRAS wild type. Many docs are stopping there and not doing any additional RAS testing, but we know that there are another 20% or so of other RAS mutations that are seen. We also know that BRAF is a negative predictor for response to the EGFR therapies. So what we're doing is doing these broad profiles now so that I know everything. So I don't have to keep up. I just test everything and I'll have in the bank what I need for an individual patient. So it's really important to have MSI, and it's really important to have broad RAS and BRAF testing for every patient with metastatic colon cancer.